Kita continue dengan 2 slot that we haven't finished, and then later kita sambung dissociation. Silakan. Saya tukar device saja. Sila. Apa present?
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Daniel bin Zubair, and inshallah I will discuss briefly about depression in childhood and adolescence. Okay, next. A bit of overview. So depression disorders are common in children and adolescents. It's not only common in adulthood, and this can impair psychosocial functioning and often accompanied by comorbid psychopathology. However, it is often undertreated. Next. A bit of epidemiology. The 12-month point prevalence is 1% pubertal and 3% post-pubertal. Initially, pre-pubertal, there is no sex difference between the prevalence, but after pubertal, female are more common to have depression in childhood and adolescence. So with a ratio of approximately 2:1. Okay, next. So these are the risk factors for children to have depression. We can divide them into vulnerability factors and environmental factors. So vulnerability means what's the childhood is facing, maknanya what is the childhood having. So such as genetic risk factors, cognitive distortion and rumination, emotion regulation, behavioral disorders and irritability. If the child has sleep deprivation, also can cause depression. And last but not least, if the child is not healthy and have comorbid medical illness.
What's cognitive distortion and rumination tu apa?
From my understanding, the child have problem always focus on the negative emotion.
Rumination?
Excuse me?
Rumination?
Rumination. That one, I'm sorry, Doctor, I forgot.
Ambil dari mana?
Kan? Rumination, I think it means the same thing.
You pernah dengar haiwan ruminasi?
Nah,
Apa benda haiwan ruminasi? Aiman.
ya. Lembu
Kenapa lembu haiwan ruminasi?
Regurgitation.
Regurgitation? Maksudnya? Apa dia buat? Apa haiwan ruminasi ni, apa yang unik about haiwan ruminasi ni?
Dia korek-korek.
Korek-korek. Apa maksudnya dia korek-korek? Dia tikus ke apa?
Kan, dia chewing.
Benda yang dia dah makan tu dia keluar balik, lepas tu dia telan balik macam tu.
Okay. So dia makan siang hari, dia telan, lepas tu malam dia keluarkan balik, dia sambung kunyah semula. So that's ruminating. So that's ruminating behavior. So apa kena mengenai dengan depression ni? Dia makan, dia kunyah balik. Macam tu.
You're always thinking the same.
Okay. So rumination in this context adalah pattern of behavior lah. Cognitive distortion dan rumination ni basically pattern of thinking styles, cara dia berfikir. So setiap orang ni ada dia punya, everyone has their own different unique way of cara mindset dia berfungsi. And it is of course influenced by many factors, intellectual kita, experience, modeling, parenting and whatnot. And so based on studies, and what they see adalah there are certain patterns of cara berfikir, the way people react to events, the way people perceive life events yang berlaku around their lives yang menyebabkan dia cenderung untuk develop depression. Contohnya dia ada one theory bagi tahu dia ada two different types of patterns of human thinking style, bottling dengan brooding. So bottling ni individu or personality or character yang bila ada problems dia simpan, dia bottle up, and so dia tak talk about it, dia tak discuss about it, they never see it as a problem, they just bottle up. Another one is brooding. Brooding ni brooding kan, menapai kan. Brooding maksudnya dia keep on talking about it, keep on thinking about it, and kalau ada satu problem tu 3-4 hari tak habis-habis hidup berfikir. And so orang yang bottling up ni dia tend untuk develop, both ways are basically not a healthy way of cara kita deal with life problems. Dia akan leads to a different form of problems later on in life lah. And so I don't know what your resources is, tapi bila anyone mention about cognitive distortion and rumination ni, is about that lah. And contohnya kalau ada contoh something happen in children's ni punya life, dia kalah at something for example, ataupun dia being bullied for example, and so ada orang they just brush it off, and maybe you all pun, and kalau reflect on your life, and some of you might have been at some point kena bully in life contohnya, and tapi some might say I'm not affected at all by what happened. Itu biasalah budak-budak dulu doktor gitu-gitu gini. And tapi ada orang yang even small things that happen to them in their life tu dia keep somewhere in dia punya emotional compartment, and yang menyebabkan bila kumpul and that eventually dia develop depression. Emotional regulation apa emotional regulation? Jangan tulis aja, you have to understand what you write, otherwise macam mana orang lain nak faham bila baca you punya lecture notes later on nanti nak exam. Emotional regulation tu apa?
From my understanding, emotion regulation means the child has problem in handling the emotion. Contoh, if the child is angry, dia ada problem in not be to calm down.
So in apa examples of children yang ada emotional regulation?
Patient yang macam ada ADHD.
Okay, kenapa?
Because ADHD patient dia sometimes dia when they obsessed in something, and ataupun if something is not going his way, and they tend to overreact. That is my understanding.
ADHD ke ASD?
ASD. Sorry.
Okay, alright. So you're talking about rigidity and autism. Okay. So basically, you are correct. Emotional regulation is our ability untuk regulate kita punya emotion. So everyone ada emotion. So part of kita punya normal human development adalah kita start feel emotion. And so even 2-3 years old dah start ada marah, dah start ada sedih bila kena marah. 5, 6, 7, 8 growing up, kita punya emotional tu akan becoming more and more complex. Apart from that, selain ability to feel emotion, kita juga at the same time developing another set of skill which is regulating the emotion. So regulating emotion ni contohnya basically regulating the emotion is knowing what to do with the emotion that we have. And contohnya budak umur 9 years old for example, at 7 years old bila kalah main, and you all pernah main dengan adik kan, main Uno ke main kad ke, Tiba-tiba dia kalah, kat dia banyak lagi orang lain menang, mengamuk-ngamuk kan. Kata mana boleh. So dia ada trouble regulating emotion. Tapi bila dia grow up, 9, 10, dia dah start boleh belajar tolerate with the frustration. Okay, tak apa, kalau next time aku menang pula, aku pandai kat benda lain. So dia ada certain abilities untuk dia regulate dia punya emotion. So growing up, the more kita becoming mature, cognitively, emotionally, brain wise, kita punya ability to regulate emotions is getting better. Tapi ada certain kids, ada certain children, they ada trouble with emotional regulation issues. Contoh yang ada autism, basically any developmental issues lah, even intellectual disability, ADHD, they will have emotional regulation problem. Dan sebab tu sometimes kita akan dapat budak yang presented dengan excessive tantrum, for example. And bila kita find out, kita get further history, so the excessive tantrum tu sebenarnya is due to problem with emotional regulation, and the problem dia ada emotional regulation, maybe dia ada intellectual disability, dia ada development problem, dia ada autism spectrum disorder, and so that's what it means. So that's one of the reason why kids yang ada neurodevelopmental disorder are at higher risk of developing mood disorder compared to other children yang ada normal development. Okay, sambung.
Okay. So environmental factors are factors that is at the environment, maknanya outside from the children. Number one is parental depression and family discord. So this family discord can directly or indirectly means scolding to the child or between parents arguing each other. And then child maltreatment. And next is peer victimization, such as what Dr. has mentioned, such as bullying, and sexual minority status. And last but not least, bereavement. So bereavement is when the children is having loss of loved one. This can cause sadness. Okay, next. So the etiology that is from my reading, the etiology of depression can be explained using the stress vulnerability model, where the stressor, the vulnerability factors interact each other. If there is high vulnerability factors, which can cause low stress threshold, and if the stressor is very high, so the child might not be able to cope, and this can cause a mental health problem. Okay, next. So screening. So according to Bright Futures /AAP, American Academy of Pediatrics, universal screening for depression is recommended to do annually from age 12 to 21 years old. However, targeted screening recommended for children more than 10 years old, which is at high risk. Those risks are there is personal or family history of depression, significant psychosocial stressors, frequent somatic complaints, or the child is in foster care or adopted. So it is recommended to use the patient health questionnaire 2-item screen, where we ask the patient, over the past 2 weeks, do you feel sad or lose interest in doing things?
In our context, kat mana kita buat screening?
Dekat school, family health care, number one. And then dekat family health care. And then the teachers also need to know about this.
You all dulu masa dekat sekolah, I don't know you all dulu form 1, form 4 tahun berapa, tapi masa dekat sekolah dulu dah ada belum saringan minda sihat? Pernah dengar?
Tak pernah.
So maybe past your age, you all dah tua lah maknanya. So I think saya pun tak ingat exact time when it started, tapi kalau sekarang ni dekat sekolah form 1 and form 4 dia orang akan ada saringan minda sihat lah, where they do dust screening for all form 1 and form 4 students lah. And so it will be conducted by school counsellors. So this is one of kita punya screening. And second one is any patients yang at range age of adolescent presented to primary care, they should be screened. And for whatever reason they come, they should be screened for psychosocial issues lah. And so itu dua je sebenarnya kita punya gatekeeping. And otherwise will be based on point of contact lah. And bila dia presented for whatever reason, if they present with any psychological related issues, we don't do, kita tak ada any other community contact screening other than this two. Tapi fair enough, I think it should be sufficient. Abang?
Okay, next. So diagnosis. I am sharing the DSM-5 criteria for major depressive disorder. So at least 5 of the following symptoms are present nearly every day during the same 2-week period as reported by the patient or observed by others. So number 1 is low mood. However, in children, this is more presented as irritability, grumpy, or moody in children. Next is anhedonia, insomnia or hypersomnia, fatigue or loss of energy, significant weight loss, psychomotor agitation, indecisiveness or poor concentration, feelings of worthlessness and appropriate guilt, and this is the most extreme recurrent thought of death, although this is in severe cases. So at least one of the symptoms is low mood or irritability or anhedonia, but as I mentioned before, irritability is more common in children. So symptoms represent a change from previous functioning, functional impairment, and also the symptoms are not clearly attributed with other medical condition or psychological, physiological effect of substance. And last but not least, there have never been a manic or hypomanic episode. Okay, next. So how do we manage the management? Briefly, we can divide into general measures, psychological treatment, and medication. So general measures, number 1, reduce the distressing circumstances and stressors. So let's say if the stressors are at school, so we need to identify what are the stressors and try to reduce the contact with the stressors. So, and then it is also important to explain carefully the nature of the disorders to parents, and also if suitable, we need to involve the teachers and schools so that the teachers will understand what is the children or is the child facing. So if general measures are not enough, we can start with psychological treatment, such as cognitive therapy, interpersonal therapy, brief family therapy, and last but not least, we can also add on medication. So based on my reading, the first line that is commonly used in children is fluoxetine. The second line are sertraline or citalopram. Next, I think that's.
Okay, all right. So for depression or depressive disorder among children, the way we diagnose it basically the same as how we approach it in adult lah, and we still go by the same diagnostic criteria. The only small exception that DSM allow dalam the diagnostic criteria is the depressed mood may present as irritability, and tapi the rest you still need sleep trouble, appetite, hopelessness, worthlessness. So still those are still required symptoms. And cuma bila when we come across adolescent ataupun even children yang presented with depression, and always remember that always remember to look for number 1 comorbid or underlying neurodevelopmental issues, and including intellectual or learning disability or difficulties, which is one of the common contributing factors. Number dua, psychosocial factors, and so children maltreatment, abuse, and so these are the things yang kita juga kena tengok. And number three, associated medical condition lah. So kalau adult normally they present with life events. So antara tiga dia ada life events. Tapi kalau in children, in the absence of life events, maksudnya tak ada any trigger, tak ada any issues, tak ada any changes in the environment, then you have to be careful regarding possibility of underlying medical problem lah. And so sometimes, for example, neurological condition macam brain tumor can present with change of behavior. And contohnya budak tu jadi withdrawn, senyap, irritable, jadi anxious. It may be actually a problem dengan brain lah. Tapi of course we need to look for other clues and other symptoms lah. Bukan nak kata semua adolescent yang present dengan behavior changes tu is a brain tumor, tapi we have to be cautious about that as well lah. And sama juga kalau patient yang presented dengan endocrine problem, they may have for example pituitary adenoma ke, they may present dengan hypothyroidism, hypocortisolism, buatkan mereka jadi slow, and so these are the things that we have to be cautious lah. And number four, kalau early onset mood symptom, one of the things that we also need to look at adalah possibility of bipolar disorder. And so one of the common presentation of bipolar disorder adalah extreme age of mood symptoms. Maksudnya dia presented dengan symptoms way before typical onset of yang kita tengok dalam general major depressive disorder. Okay, alright. So those are the things that you have to be careful. The way we treat, the way we manage is pretty much the same as adult lah. And so we look at formulation, biopsychosocial predisposing factors, perpetuating factors, and kita decide based on that. And cuma ada certain form of therapy tu maybe not suitable for children and adolescent depending on dia punya age. Okay, sambung. Apa contoh skrin?
Okay, all right. I will be proceeding with the next one, that is conduct disorder. My name is Ankalida with my team. Okay, next. So the definition by DSM-5 is that conduct disorder is a repetitive and persistent pattern of behavior in which the basic rights of others or major age-appropriate societal norms or rules are violated. And it is manifested by the presence of at least 3 out of 5 in the DSM-5 criteria. Okay, I'll be explaining later. So conduct disorder is characterized by aggressive behavior towards person or animals, destruction of property, deceitfulness or theft, and also violation of rules. So the prevalence of conduct disorder is around 2 to 10%, and male is more common with the ratio of 4 to 1. Yes, 4 to 1. So there are 3 subtypes of conduct disorder. First is childhood onset, in which it presents in children less than 10 years old, and then adolescent, it is after 10 years old, and unspecified onset. Usually, the patient would present with comorbidities such as the common one, ADHD, and also oppositional defiant disorder, ODD, which might which they might have worse outcome in the future. So ODD is when they have emotional dysregulation without any violation. So for the etiology, it can be divided into parental, child, and also other psychosocial factors. So for parental factors, it can be due to parental criminality, parental psychiatric disorder, parental substance abuse, inconsistent style of parenting, parental conflict, domestic violence, and even child abuse, and also child maltreatment. For child factors, it can be due to genetic that is linked to aggressive behavior. For neurobiological, it can be there is damage in the brain structure and function, and patient could also be having low IQ level. For other psychosocial factors, it could be poverty, low socioeconomic class, bad neighborhood, and also peer influence when they are associated with the antisocial friends and truancy. Okay, so for the clinical features, basically, for younger children, they tend to have a milder form of conduct disorder, in which they have general defiance, disobey of instructions, and for adolescents, they could hurt other people, assault, robbery, and even drug abuse. Okay, so this is the DSM-5 diagnostic criteria of conduct disorder. So it must a repetitive and persistent pattern of behavior in which basic rights of others are violated, manifested by presence of at least 3 of the following 15 criteria in the past 12 months, and at least 1 criteria present in the past 6 months. So first is aggression to people and animals. So they are often bully, threaten, or intimidate others. They initiate in physical fights, use weapon. They can be physically cruel to people or even animals. They can steal while confronting a victim and force someone into sexual activity. For destruction of property, they can deliberately engage in fire setting with the intention of causing serious damage and then destroy others' property. For deceitfulness or theft, they broke into someone else's house, building, or car, and then often lies to obtain goods. And then they can steal items of non-trivial value without confronting a victim. And lastly is serious violations of rules. They often stay out at night despite parental prohibitions that begin before 13 years old. And then they run away from home overnight at least twice. And then they are often thrown from school before the age of 13 years old. And these disturbances of behavior causes clinically significant impairment in social, academic, or occupational functioning. Okay. So for the specifier of conduct disorder, so to qualify this specifier that is with limited prosocial emotion, the child must have at least 2 of the following characteristics that persistently present over at least 12 months, which are lack of remorse or guilt when they do something wrong, and then careless or lack of empathy, in which they are unconcerned about the feelings of others, and then they are unconcerned about their poor performance at school or even at work, and they are shallow or have deficient affect, in which they doesn't express feelings or show emotions except in a way that seems shallow, insincere, and also superficial. We must also specify them according to the specific type of onset, whether it is childhood or adolescent, and specify according to severity, mild, moderate, or severe. So the differential diagnosis of conduct disorder is first is oppositional defiant disorder. It is solely emotional dysregulation, and there is no violation of others' rights compared to conduct disorder. And then ADHD, in which they have hyperactive and impulsive behavior. However, they doesn't violate others' rights. And then depressive and bipolar, in which it is mood disorder. For conduct disorder, there is no mood disturbance. And other differential diagnoses are ASD, intermittent explosive disorder, and also adjustment disorder. Okay, so lastly, treatment. For the psychosocial intervention, first we can do parenting skill, in which we can give parent management training for the parents. So the element in the parent management training is that we can teach the parent to promote a play and positive relationship with their children, and then praise and rewards for prosocial behavior. And then they must give clear rules and commands to their children. And then they must be consistent and calm consequences for any unwanted behavior of their children, and reorganize the child's day to prevent any trouble. Next is family functioning. So for the functional family therapy, to improve communication, reduce interparental inconsistency, and then tighten up the supervision and monitoring on the children, and negotiate rules with their children. And then we can do multi-systemic therapy, in which it involves other systems such as schools, peers. Okay. And then anger management and child interpersonal skills, in which we can teach the children to slow down and control their impulsive response. And then difficulties at school, we can help the children with their problem with learning and also communication in school. And lastly is peer group influences, in which the children can join a small group, of good friends. Lastly is psychopharmacologic interventions. It is not routinely prescribed for the patients. However, it can be given if they are having comorbid hyperactivity. So we can give a typical antipsychotic such as risperidone. So it is a short-term management for severely aggressive behavior when psychosocial interventions are not successful. I think that's all from me. Thank you.
So conduct and ODD ni something that you'll revisit again nanti next year lah, bila you go through the posting for year 5 nanti. Tapi as an introduction, as I mentioned earlier, when mental health issues involve children, it can affect either 4 areas lah. So developmental, academic, emotional dengan behavior. So when it comes to behavior, one of the most common reason behind it is OCD, ODD dengan conduct related behavior lah. But normally bila patients presented to clinic with behavioral problem, kalau dia datang dengan specific behavioral problem, for example datang sebab kena mencuri ke, datang sebab buat damage to the properties ke, datang sebab ada abnormal behavior, killing animal dan sebagainya. So we don't straight away say diagnose the child as a conduct lah. And so normally what we do is an extensive investigation, biological history examination, relevant biological investigation, psychological investigation untuk kita find out the overall picture what happened lah. We don't just go by the list apa yang listed in the DSM, because most of the time ODD tu can be either number one psychosocial factors or number two as a manifestation of underlying psychiatric problem. And many, I would say majority of children yang datang to my clinic with behavioral problem, underneath it normally adalah neurodevelopmental related. And for example, I have cases presented dengan mencuri, and ada quite a few yang datang sebab mencuri. So caught mencuri by parents, repetitive behavior, and so bila parents concerned, somebody suggested untuk dapat psychiatric opinion assessment, so end up come to my clinic, and bila kita go through the history, go through the presentation, and some either ada issues with cognitive, so dia mencuri tu for the sake of dia mencuri sebab dia tak tahu what the consequences of the behavior, and tak tahu pun sebenarnya tak boleh ambil duit orang, tak tahu pun it's morally or legally wrong, for example. So looking back from the history, then only kita dapat pattern of ada delay and ada issues in academic, not interested in study, dropping off school, and ataupun yang kedua ADHD related. And so there are quite a few cases as well yang apart from the behavior problem tu is actually the manifestation of which element of ADHD. Yang mana yang which element of ADHD yang contribute to behavioral problem. Kalau mencuri tu apa kaitan dengan ADHD? Macam how do you relate ADHD dengan dia mencuri? Ada orang ke tak ni? Ada 140 satu batch, takkan seorang pun tak nak respon.
Impulsivity, doktor.
Compulsive.
Okay, good. So impulsivity. Okay, so kalau kecil-kecil masa 5-6 tahun, impulsivity dia mungkin interrupt others, intrude other space and cannot wait for turn. So that's dia punya impulsivity. Tapi as dia grow up, bila dia masuk 17-18, impulsivity dia tak ada main dah. Dia tak beratur dekat tepi, beratur nak naik gelongsor. So you won't see that kind of impulsivity. You'll see a different form of impulsivity. And so sometimes ada yang contohnya tak ada parental guidance and ataupun ada associated intellectual issues, so dia resort to behavioral problem. And so contohnya dia kawan dengan member yang jenis main game ke, member yang jenis vaping ke, and so member tu mak ayah bagi duit ke contohnya, so dia tak ada duit, mak ayah dia pula jenis yang control. So macam ni nak dapat access to vaping, online game, bayar CC dan sebagainya. And so because of the impulsivity, dia rasa aku kena juga dapatkan duit, so whatever it takes. And so itu yang dia start ambil duit daripada ni lah, daripada orang lain. Ataupun third underlying possibilities adalah psychosocial issues lah. Psychosocial issues ni contohnya macam neglected child, ataupun parents model certain behaviours. Mak ayah pun mencuri juga, so sometimes you see that kind of behaviour. So jarang yang kita diagnose conduct and soul conduct. Recently saya ada satu case yang tadi saya tengok dekat klinik, 9 years old, adopted child. Child ni is a product of rape lah. And so mak dia tak nak dia, unwanted pregnancy. So lahir, mother dia punya kakak take the child, adopt the child lah. And so dia dijaga oleh dia punya mak saudara. And so what happened is dia memang ada issues with attachment and rejection lah. And so dia punya nenek atau mak sendiri kind of rejected dia. Lepas tu mak angkat dia ni ataupun dia punya auntie yang jaga dia ni overcompensate lah. And so because of what happened to the child, so dia overcompensate by permissive parenting. And so dia allow semua benda, dia allow ikut dia budak tu punya tu. And tapi bila dia makin besar, dia punya mother, adopted mother ni having struggle to cope dengan budak dia punya demand. And so dia start threatening, and contohnya kalau dia tak dapat sesuatu, dia threat nak terjun dia punya flat, nak buka pintu masa kereta tengah berjalan. And lepas tu very provocative, and so melawan, tak nak dengar cakap. Bila dia tantrum, mengamuk, nak something and tak dapat ataupun tak boleh, dia damage, paling telefon, pecahkan TV dan sebagainya. 9-year-old girl lah. And so eventually referred to me. Tapi bila saya tengok, bila saya assess, true enough, if you look at the symptoms checklist tu, memang dia ada all the ODD punya, all the conducts punya symptoms. So persistent, more than 3 symptoms. And so dia relates well dengan conduct. Tapi we do not stop there kan. And so like I said earlier, we have to go to understand why it happened. And along the same line, bila kita assess dia punya academic, dia punya performance, and we noted that dia memang ada trouble. Dah umur 9 tahun dia tak boleh baca, very poorly in academic abilities lah. And so bila assess for ADHD, memang ada ADHD punya traits lah. And so attachment problem, parenting style, that contributes to the behavior. Tapi apa yang juga contribute to the behavior adalah because of dia ada ADHD, dia punya brain ada problem dengan coping with emotional regulation task lah. And so dia ada low threshold to frustration, so ada problem. So what we did was, number one, we have to treat the underlying cause first. And so we treat the ADHD. So kita start patients on methylphenidate and bagi patient methylphenidate Ritalin. We refer parents untuk parenting punya education. So retrain the adopted mother tu untuk cara nak control the behavior, and the child tu kita engage lah, and kita do supportive therapy dengan the child, play therapy dengan the child. So hari ni dah saya rasa 4 ke 5 kali saya jumpa dia. Hari ni appointment hari ni very cheerful, very forthcoming. Mak dia pun happy and dah tak stress dah, sebab budak ni dah more manageable. Still struggling untuk belajar, still tak minat, tak interested dengan belajar, and one of the reason is because dia dah left out quite significantly, dan PDPR does not help either. And tapi in term of behavior dah tak ada dah tantrum, dah tak ada dah mengamuk, dah tak ada dah hyperactivity, dah tak ada dah risky behavior, dah tak ada dah melawan, so a lot more manageable. And so what helps sebenarnya bukan ubat tu is one factor, biological one factor. And Psychosocial pun another factor yang helps. And so bila budak tu dah start ada, bila mother dia dah ada, dia punya adopted mother tu dah ada understanding with dia punya, dah ada more understanding dengan dia punya, orang kata, dengan dia punya masalah. So dia lebih accepting, lebih menerima, dan kurang, kita kata apa, dah tak permissive sangat, dah put some limits and boundaries. So dia punya behavior to improve. Okay, so that's one example where what we see in child psychiatric clinics lah. Okay, alright, thank you. Are there any questions related to child and adolescent psychiatry sebelum kita move on to dissociative disorder? Ada any question?
Betul. I just want to ask, suicide in children and adolescent is common or not?
Suicide and adolescent, you rasa?
I think not common.
Kalau you baca tak PDRM punya report tentang suicide di Malaysia? You ni baca pengetahuan umum ke tak?
Tak kot.
Ada berapa kes suicide berlaku sepanjang 2000 reported suicide to PDRM? Ni data according to PDRM dekat Malaysia ni. Oh, kena tahulah. You tahu tak orang suicide masa pandemik COVID-19 ni? Ke orang, you rasa semua orang happy, semua orang bahagia?
Tahu lah tak, cuma tak tahu dia punya sumber yang legit.
Okay. Kali Google lah. And so
500.
Macam mana?
468 suicides in the first 5 months.
Okay, alright. And is that a lot? Is that less? Is that many? Apa tu?
That's a lot. For the first 5 months too, that's a lot.
Okay, alright. So kalau globally there are 800,000 cases of suicide yearly, which is basically translated into one suicide cases every 40 seconds. Tapi ini general suicide cases. And tapi if you break it down to ages, and sebenarnya most will occur during adulthood. Yet we still see suicide occur in children and adolescent group, increasingly in pattern each year lah. And so kalau globally speaking, suicide ni second cause of death. Second most common cause of death among children and adolescent. So children and adolescent maksudnya daripada 0 sampai 18 lah. Second most common. The first one being motor vehicle accident, and then suicide lah. Cumanya what's interesting, kalau dekat Malaysia, generally speaking, children and adolescent suicide ni tak banyak. Tapi bila kita study National Mobility Health Survey, we find out that 1 in 10 adolescent, 1 in 10, 13 to 18 years old, reported suicide ideation. 1 in 10 reported suicide attempt, ideation, betul lah, suicide ideation, and 1 in 10 reported suicide ideation. So ideation and attempt. So ideation and attempt of suicide tu is not uncommon sebenarnya, and this is actually a figure yang comes from community study, bukan clinical, bukan maksudnya bukan kita select patients yang dekat ward, patients yang datang psychiatric clinic, tapi patients in the community, budak-budak sekolah, 1 in 10. And more interestingly, bila kita tengok recent study atau recent reported data tentang suicide, kita dapati almost 2/3 of suicide cases for the last 3 years, 2020, 2021, and first half, basically first 5 months of 2021, 2/3 of the cases tu sebenarnya involving adolescent. So this data is actually worrying for us as a psychiatrist, and tapi we do not have anything to back up the data, sama ada to support or to go against the data. Sebab data tu what's presented by PDRM. So sama ada the figure tu banyak macam tu disebabkan adult punya cases underreported, and ataupun memang itulah sebenarnya true representative of cases of suicide among adolescent, we don't know. Sebab we only have figure by that. And sebab case suicide ni dia tak report to psychiatry, dia report to mortuary kan. And jadi we don't know the context of the data. Tapi that's what happened lah. So if you ask me, is it common? It is probably not as common as COVID. You don't see it, thousands of cases. And tapi from statistic perspective, from suicide perspective, it's actually quite common lah, and especially yang related to self-harming behavior. Okay.
Alright, thank you, Dr.
Thank you, Doctor. I have a question. Just now cakap pasal screening kan, like we are screening for the like depression in like adolescent and also like autism kan. So what about ADHD? Dia punya screening tu like kat mana? Like kan sebab ADHD we need to have like two different, apa panggil, dua kat beza kan, either at home ataupun at school.
So ADHD ni tak ada, ADHD ada screening tools tapi tak ada screening measures yang implemented locally. So kita tak ada. Yang ada adalah untuk intellectual disability kita screen through school. Maknanya generally speaking they have one informal form of screening there. Untuk ASD kita ada screening masa developmental screening, masa dia 18 bulan, 3 tahun, masa dia vaccination. Tapi tak ada. And cumanya ADHD ni biasanya dia akan affect academic. So selalunya teachers is another screening, gatekeeping. Yang kedua, sebab tu kalau siapa yang train untuk jadi family medicine, siapa yang train untuk family medicine, one of the posting wajib dia adalah untuk buat psychiatry, and then one of the posting wajib dalam psychiatry adalah dia kena belajar child psychiatry. And sebab we want them to be able untuk be part of the first line assessor untuk neurodevelopmental disorder juga. And so kalau dia tak tahu, we don't know. Contohnya kalau macam rare condition, optic neuritis ke apa ke, we don't screen it and we don't generally do that. And tapi for children, because generally they will come to clinic for whatever reason, and so one of the things that we look at is the general behavior of the child. And so you have to know lah. And so kalau let's say you all nanti end up tak jadi doctors in the hospital, you work in a clinic settings ke, you work in private settings ke, whenever you have to encounter with children, at least ingatlah kita pernah bercakap tentang ASD, ADHD pada musim ini dalam kehidupan korang masa korang year 4 ni, at least you all have some ideas lah. And sebab true enough, kalau you all tak end up doing psychiatry, tak end up doing pediatrics, you end up doing something else, you might not think about this lah. Tapi nanti you all semua jadi parents, you all kena tahu juga lah. So one of the reason kita tak do screening wajib adalah kerana dia bukan something yang very common lah. Maksudnya dia bukan something yang life threatening. Kita tak screen semua. So what we do adalah kita increase awareness public lah tentang this problem, at least public aware. And most of referrals yang datang kat klinik kita pun is sama ada parents yang concern atau teachers yang concern. And jarang-jarang je yang ada referral daripada klinik sebab tak lepas MCAT, jarang-jarang. Sebab kalau if you look back, banyak yang sebenarnya parents kata, oh anak saya pergi masih kecil vaksin semua tu, doktor kata tak ada apa, tak ada problem. And because sebenarnya kalau dia datang untuk vaksin, untuk you tiba-tiba nak tanya pasal perkembangan development, sebenarnya sometimes it doesn't happen in real life. I can tell you. Saya pun ada anak yang kecil bawa pergi vaksin. Dan lagi-lagi kalau anak doktor ni, orang yang ada anak-anak pergi klinik ni, kena jaga-jaga lah. Kadang-kadang people tend to under-examine and kita punya children. Dan sebab dia rasa tak apa, mak pak dia doktor, kalau ada problem dia tahulah. Padahal anak-anak doktor kan mak autism ni. Sebab tu kena keep up knowledge. Nanti dah kahwin, nanti baca buku saya. Tak kahwin lagi tak baca tak apa. At least ada some ideas how to parent your child. Nanti kan dalam sibuk kerja, houseman, anak tinggal kat rumah, tak cukup kasih sayang, and that 5 years, 5-6 years down the track, your children yang suffer. Okay, ada last question, any last questions? Kalau tak ada, kita continue discussion tentang dissociative disorder. So hopefully you all have some ideas pasal apa namanya? Pasal pasal apa child related topic ni. Tak ada question So kalau tak ada question, kita beralih kepada dissociative disorder. Kita rehat sekejap lah. Kita rehat break, toilet break 5 minutes. We'll come back at 3:30 Sekejap je kita nak discuss dissociative disorder. Anything that you were not sure from the lecture notes. You semua dah, saya bagi kat siapa saya tak ingat. Saya bagi kat Sambal ke? Ke bagi dekat Cik Alif? Lecture recording dissociative disorder. You semua dah tengok dah kan? Alright, we'll discuss about it later. So see you. Okay, thank you. Right, bismillah. So kita sambung another part of the discussion, which is on the actual topic yang supposed to be presented today lah. And tapi I won't present the whole thing because I've already given you the lecture for you to have a look at. And kalau saya present on the topic, that what I will be presenting lah, because the topic remains the same regardless last year ke 2 years ago ke. There's no new theory or no new development in the management of dissociative disorder lah. And cumanya dissociative disorder ni is a minor topic in psychiatry. We don't see a lot of cases related to dissociative disorder in clinical context. Tapi interestingly, while you are undergoing this current posting now, I have one patient in the ward who's presented with dissociative symptom, with dissociative identity disorder. And so it's rare. In fact, kalau sebelum ni saya selalu sebut, and throughout my career in psychiatry for the last 10 years ni, I have less than handful of cases, tak sampai 2-3 cases pun yang ada dissociative identity disorder or dissociative disorder per se. And tapi you still have to, I mean as a psychiatrist, you still have to know about it, the principles behind it, because even though it's rare, if it happens, it has to be managed. And so for all of you, you are the first batch that we revisit the curriculum. And so dissociative disorder ni will only be covered during 4th year. So next year there will be no more lectures on dissociative disorder lah. So this is probably your only opportunity throughout your career in medicine to learn about dissociative disorder. Kalau if you come back to psychiatry at some point in life as a career, then you might see it again. Kalau tak, maybe kat sini lah dia berakhir. And tapi as I said, bukanlah kita nak you faham dissociative disorder tu macam as a psychiatrist, tapi at least have some idea lah. So what I'll do is I have few questions that I've prepared that I want you all to answer, and so we'll discuss about it from the discussion lah. Maybe I'll just start dengan sharing with you the patients that I had in the ward currently lah. And so maybe you all tak ada, by the time you all masuk year 5 nanti, hopefully lah patient tu tak ada dekat ward, so it's very unlikely you'll see the patients in real life lah. So I have a patient, male, currently 16 years old, 16-year-old male, Malay male student, who was first presented to me back in 2020. So he was referred to me by chance. What I mean by that, basically his brother was admitted to psychiatric ward for suicidal injection, for paracetamol injection in overdose setting. So his brother at that time was 20, I think, if I'm not mistaken. So it happened that during brother's dia punya admission tu, I had the brother was not my patient. I had a talk in one of the masjid in Kuantan ni. So his father came across my poster. I was talking about psychology, adolescent psychology at that time. Saya cakap tentang psikologi memahami remaja, something like that lah. So after the talk tu, his father came to me. And personally and sharing about his problem with his brother lah. So the way he described his brother clicked in my mind at that time. His brother sounded macam somebody yang ada autism spectrum disorder. So his brother memang ada memang high functioning and very smart, and duduk asrama penuh and whatnot. Tapi ada very poor social skills. And in looking back at some of the history yang father dia cerita to me tu, I made a conclusion at that time. I made an impression at that time. It sounds macam your son ada underlying neurodevelopmental disorder. So he was discharged from the ward and then follow up in the clinic. But along the line tu, after jumpa MO semua tu, father request to see me lah. So I met the brother. At that time, brother was already well. So he's over the depressive episode, no longer suicidal, and on the process of pursuing his study elsewhere. And but then the father actually told me that I have another son who I think have the same problem. And so this is when I had the father referred the son to me, and saw the son at Suspect at the time in my child clinic over there. At that time, he was in his Form 1 going Form 2. So he presented with basically aggressive behavior. He was throwing tantrum, and the underlying stories behind the tantrum was related to his rigidity in behavior. He refused to go to school, and there was an element of bullying related to that episode lah. But he was not depressed. There was no full syndromic picture of depression. But as I mentioned earlier, whenever an adolescent presented with depressed-like presentation, you have to think about other associated problem lah. So of course we went through the developmental history, and then from there it was clear that the child to actually ada autism spectrum disorder. So it was not noticed until when he presented, because his symptom was mild and it was masked by the fact that he was functionally well, and so he was able to look after himself. Tak ada any delay in other domains. Dia ada delay in speech tapi other domains normal. And in fact bila dah start bercakap tu dekat sekolah dia normal, tapi there's something's not right lah. And so in a sense that budak ni tak ada kawan, cara bercakap dia very odd, dia cakap macam bunyi-bunyi tak bunyi Melayu lah, and slang. And lepas tu tak ada eye contact, and very one-sided bila bercakap, ada robotic gait, very clumsy. So you know from physical examination plus history tu, the child has autism spectrum disorder lah. So that was when we first diagnosed this child as autism spectrum disorder. So along the way we continue treating him. I didn't start him on any medication. He was not substantially depressed to start medication, but kita refer untuk occupational therapy, for social skill training, refer for psychology, untuk parental education, cara nak manage dia, cara nak talk to him, and I see him on regular basis, monthly to monthly, untuk for supportive lah mainly. So he changed school, lepas tu dia masuk Form 2, Form 3, so there was no major issues until bila PKP this year, the third PKP, father noted there's a decline in dia punya functioning. Dia tak nak keluar bilik, tak nak cakap dengan orang, kemudian dia refuse to join activities in OT yang before this dia participate sahaja, refuse to go to OT, occupational therapist punya appointment. Lepas tu dia during the last 1 month before admission ni, dia presented with catatonic behavior lah. And so his catatonia was dia immobile, basically posturing. So berdiri ataupun duduk, stuporous lah, and do not respond to any external stimuli, mute, negativism, do not follow instruction. There were periods yang ayah dia bagi example tengah-tengah makan dan stop tangan halfway for 20 minutes or so, and then overall functioning tu decline, tak mandi, semayang buat lagi, tak nak involve with class, tak cakap dengan orang. The only person yang dia communicate was his father lah. There were some psychological issues, psychosocial, there were some family issues related to that lah. And so dia macam kind of estranged within the family lah. And sebab mak dia frustrated dengan dia, mak dia jenis yang tak tahu macam mana nak cope, macam mana nak communicate dengan dia given dia punya current situation. Brothers takut dengan dia, kakak moving overseas, mate yang baik dengan dia going back to Indonesia. So the all isolation issues yang berlaku tu menyebabkan dia even possibly triggered the most recent episode lah. So we admit him to basically when he became like that, we call him up for interview, we call him up for appointment, early appointment. He came to clinic dan dia basically catatonic in the clinic lah, and so did not answer any questions, did not move at all dekat seat. So kita bawa dia ke emergency department. We did whole investigation, blood's normal, despite dia tak berapa nak makan. We did CT brain, tak ada anything yang suggestive of any organic cause found. So we discharge him sebab dia lepas tu okay. Coming back, catatonic again. So the second presentation a week later tu, kita refresh TA for admission lah. And so admission ni sebab dia come to the point where dia tak makan, tak minum, so it's harmful. So catatonia ni boleh jadi lethal for two reasons. Satu, sebab dia tak makan, tak minum. Kedua, sebab apa? Sebab apa orang catatonic boleh mati? Ni macam saya cakap dengan dinding. Ada orang ke tak ni? Ada 130 ni. Why do you think patients in catatonic can die? Hello? Ada orang ke tak?
Complication of immobility ke doktor?
What? Apa complication of immobility yang boleh buat orang mati?
Pulmonary embolism.
Sorry?
Pulmonary embolism.
Okay, true. Primary embolism. Lagi?
Dehydration.
Dehydration tu tak makan, tak minum lah. Lagi? Ha? Respiratory tak, dia tak affect breathing pun, dia breathing normally je. Rhabdomyolysis, rhabdomyolysis. So bila dia maintain certain odd postures for long time, you tahu berapa lama dia berdiri, this particular patient. He has been standing for 8 hours, immobilized. And so there are patients yang even become catatonic even longer than that. And so itu yang sampai tahap ada yang dapat muscle breakdown. So bila you ada rhabdomyolysis, what happen? What happened bila you ada rhabdomyolysis?
AKI.
AKI.
Okay, so you ada acute kidney injury. Bila you ada acute kidney injury, you ada electrolyte imbalance. So when you have electrolyte imbalance, anything can happen. And so you punya heart can stop, and because of electrolyte imbalance. So there's a risk lah. So there's a risk. Even before that, dia dah ada catatonic for the last 1 month, tapi we cannot keep him that way lah. And second is sebab kita nak investigate further what happened lah. We cannot leave him to outpatient. Setiap kali outpatient lambat datang, tak datang ke, so kita kena help him out in that way lah. So admit in the ward. So bila admit in the ward, that's only when kita boleh dapat dig further history lah. And sebab kita ada plenty more opportunities, so kita jumpa dia 2-3 kali sehari. Bila dia okey sikit, dia bercakap. Dia tak bercakap, kita bagi dia rehat. Bila dia bercakap, kita get history. So from there, then only kita dapat history that dia kata yang tak bergerak tu sebenarnya adalah one of his personality. So dia talk about 7 personalities. So ada 7 personalities yang dia ada. So each personalities tu ada dia punya nama dan ada dia punya karakter dan ada dia punya sifat lah. And so for example, the one that make him catatonic tu and not moving tu is the personality yang previously was very angry, and so yang aggressive tu was due to this personality, but dia kata recently this personality has changed dia punya style to in becoming more macam apa senyap. And so senyap tu is the way dia control dia punya anger, and so that's one of dia punya personality character lah. And so ada different other personality, ada yang happy tu yang boleh bercakap, yang yang boleh respond to our questions, yang makan. Dan ada personality yang tak makan, ada personality yang athletics, and there were periods yang budak ni memang dia berjalan kaki daripada sekolah dia ke rumah dia, which basically sangat jauh lah. Dan kalau daripada Irsyad tu ke Bukit Istana tu boleh imagine berapa jauh, naik kereta pun almost half an hour, 40 minutes kalau waktu jam. And so there were kita panggil alters ataupun personality lah yang behave in such way lah. So normally bila patient presented dengan this kind of presentation, the first thing that we had in mind is apa? The patient presented dengan dissociative presentation. Apa yang kita terus fikirkan? Hello. Dia dah dengar lecture dissociation kan? So apa yang tema yang selalu recurring for each dissociative disorder tu, apa common subject yang kita selalu talk about?
Dissociative identity disorder.
Kan tu diagnosis dia. So dia of course dia presented dengan dissociative identity disorder, tapi apa benda yang kita nak tahu? Apa underlying issues yang kita kena explore, we need to explore.
Ada history of trauma ke tak?
Okay, good. And so normally most of the time we will find out there is an element of trauma lah. And so bila budak ni presenter macam ni, dan tu benda pertama yang kita terus fikirkan lah. And because you don't see dissociative disorder every day, and you don't see patients yang ada dissociation on regular basis. So when you have one, always think about possibility of this child is actually present with some sort of trauma lah. I have another case yang ada dissociative disorder I have another case yang presented dengan catatonia, yang in that case particularly very clear dia presented dengan one of the reasons complaint that time was he was abused by his father, he was sexually abused by his father. And tapi this particular case kita tak tahu, we don't know what happened. And so we had the history of dia developing macam tu, tapi kita tak dapat lagi any trauma. So those are the things yang kita try dengan explore. There was bukanlah small, tapi maknanya there were episodes of kita panggil childhood adversity, because of dia punya ASD tu, dia being bullied at school, being humiliated at school, lepas tu ada family disharmony, parental discord, lepas tu isolated by families and whatnot yang berlaku. And tapi tak ada yang really traumatic yang kita dapat so far lah. And tapi at the same time we also need to understand that we are talking about 16 years old with autism spectrum disorder, and so we cannot equate dia punya experience tu dengan somebody yang normal, somebody yang typical development. And so maybe there were things yang happen in his life yang to us from our point of view as an adult or as a typical growing person, tak rasa dia as a trauma, tapi pada dia it's traumatic lah. And so we're still treating him, we are treating dia punya we're treating him with antidepressant, given that bila kita look at the history tu, there were elements of depressive lah, and dia dah start giving up main game, tidur tak boleh, and so we're treating him for depression as well. We're treating his catatonic with benzodiazepine, and tapi we haven't started him on anything else, and we are still in the process of basically doing family interview, family intervention, exploring lagi lah. And so that is something yang rare, you don't see a lot, tapi that's how dissociative identity disorder or dissociative disorder present lah. So the way dia present, even though saya cerita pasal the 7 personality, nama ni, behavior macam ni, tapi the information yang we get tu bukan macam tu segedebuk macam tu lah. And so it was very challenging to get the history, and pergi sekejap, duduk sejam, cakap dengan dia 20 minit je, the rest tu dia kerah and dapatlah 1 or 2 stories. And then pergi lagi another session in the afternoon, cakap lagi, and so kena sabar lah. And so that's what we get so far lah. So the picture is basically it is clearer than before, tapi I think it's still far from helping him out lah. And so hari ni saya tak tengok dia, hari ni saya dekat suspect. Tapi I heard from my MO tadi, pagi tadi pun dah tak nak bercakap balik. And so probably we haven't seen him for weekend, for 2 days on the weekend. So we don't know what happened. And so it's challenging to treat and manage case macam ni. Tapi that's what happened lah. Okay, before saya pergi ke questions, anything you want to ask with regards to dissociative disorder from apa yang saya cerita tu? Ada apa-apa nak tanya? Kalau you tak tengok lagi, I'm sorry lah, I cannot help you. You might not be able to relate anything. Sorry. Saya pun tak tahu berapa lama saya cakap seorang-seorang tadi. Sebelum ni pun saya cakap seorang-seorang juga. Tapi sebab you all pun senyap, saya pun ingat you all mendengar macam biasa je. Saya sampai mana tadi sebelum saya hang tadi?
Tadi masa Kak Doktor tanya soalan.
Apa soalan saya?
Doktor tanya subscription.
Apa?
Any question Doktor tanya tadi sebelum nak start session yang sepatutnya lah.
Soalan siapa tu? Saya siapa tadi? Adha. Siapa yang tanya soalan tadi tu?
Ya saya Doktor.
Soalan Adha tu saya jawab sepanjang-panjang tu, dia tak dengar lah.
Tak dengar Doktor, sorry.
Senyap.
So saya sebab you all pun kalau tak pun senyap juga. Jadi saya dah ingat you all tu dah mendengar. Aduh, letih saya jawab kat 5-6 minit jugalah saya menjawab. Sampailah saya pasang saya punya kamera tak bergerak. Hang ke saya. Lepas tu tanya-tanya you all tak jawab dah. Lepas tu saya punya laptop hang. Tak apalah. Saya pun letih nak ulang. Tapi basically macam saya sebut, dissociation is not something that you can treat with medication per se. So it's a complex psychological issues that happen to an individual, tapi dia originated from a failure of defense mechanism. And so cara kita nak bantu dia adalah through kita help dia regain insight of what happened and regain control over what happened in dia punya life lah. And so contoh kalau somebody tu yang being abused, and so dia punya kalau dia being abused physically, you akan nampak dia punya bruises ke, patah kaki, patah tangan ke. So how do you get them to be healthy again? Is you treat dia punya whatever physical damage that has happened. So physical damage tu can be as little as just a scratch or sampai orang masuk ICU. So bila orang tu masuk ICU, so of course in order untuk recover, dia akan take time, dia akan ambil masa, and sometimes they can't even go back to dia punya baseline functioning. So that's physical. So kalau you imagine the same thing happen to dia punya psychological after being traumatized, And so the trauma, the emotional trauma or the psychological trauma that happened to a person can be as little as, oh kecilnya hati aku kau cakap macam tu, to somebody yang sampai dapat suicidal, dissociation, disordered personality, jadi psikopat dan sebagainya. And so it's very complex, and tapi we are dealing so we are dealing with the same thing but on different dimension. So kalau physical, it's easy to treat given that you can see. And even then, sometimes it's difficult juga to treat, and sebab you are dealing with multiple trauma, for example. And so you ada you require intensive care. And tapi emotional bukan sekadar complicated, tapi on top of that we cannot see. And so we can only assess what happened in one's mind through apa yang dia kongsikan. But the problem and the trouble is not everybody boleh readily volunteer out apa yang dia punya experience. And sebab kita ada, kalau you all ingat dulu belajar masa year 1, ada conscious, subconscious, unconscious. And so bukan semua benda yang kita experience ni kita ingat. And ada benda yang dia buried underneath and yang memerlukan time untuk orang tu luahkan dan cerita. And so that's where nanti all belajar tentang psychodynamic psychotherapy comes into place. And so we need to help them to regain balik dia punya stability. And so it takes all aspects. And so buat dia rasa selamat balik, improve dia punya relationship with dia punya parents, remove dia from potential things yang akan remind dia to the trauma, and treat the underlying associated problem, depression ke anxiety ke. And tapi yang even more challenging in this case adalah we are dealing with a traumatized person with dissociative identity disorder who at the first place ada struggle to make sense of life due to dia punya autism spectrum disorder. And so it's a challenging thing, and tapi something that we have to deal with lah. And otherwise budak ni akan scarred for life lah. And so ni baru umur 16, we don't know what happen in the future just yet. And sekolah, belajar, relationship, family dan sebagainya. So itu dah kerja as a psychiatrist ni. It is not easy. We don't do sophisticated surgery, we don't do sophisticated investigation, and tapi we touch the most fundamental part of human being lah. Okay, saya nak share soalan. Kita akan discuss the case with soalan lah. Okay, so ini contoh-contoh soalan lah. And so this is a random question, bukan random question, maknanya random way of asking questions. Tak follow any certain format. So it may not reflect apa yang akan keluar exam nanti. Tapi these are the basic things yang kalau kita tanya pun lebih kurang macam ni je lah. Okay. So I'm hoping to have volunteers to jawab. Saya tak lagi ada nak sebut satu-satu nama, you all bukan budak tadika. And so volunteer je lah siapa nak jawab. Siapa yang tak nak jawab, siapa yang nak duduk diam je lah. And siapa yang nak jawab boleh participate, tak ada masalah. Alright, so the first question is kita jawab true and false sorry true and false, but yang ni single answer questions. So dissociation is a disorder, syndrome, symptom, coping mechanism or defense mechanism?
Defense mechanism.
Defense.
Apa beza defense mechanism dengan coping mechanism? Apa beza defense mechanism and coping mechanism?
Defense dia avoid the problem kot. Kalau coping dia
Unconscious.
face. Unconscious.
Apa jawab unconscious tadi tu?
Nafis.
Okay, so true. So beza dia, dua-dua ni adalah the way we cope with conflicts or stressor in life. Make it that explain the term mechanism of dealing with problem lah. And so coping and defense ni bezanya adalah coping ni is conscious. Conscious ni maksudnya something that you voluntarily choose. Contohnya kalau saya tanya siapa tanya Zul lah, Zulkifli. Macam mana cara you cope dengan problem?
Kadang-kadang saya makan, tidur,
Alright. So
Kolmak.
okay. And so makan, tidur, kolmak tu semua berlaku secara conscious dan voluntary, betul? Ke you macam bila ada masalah je badan you bergerak, you pun pergi dekat kafe, order makanan nasi goreng paprik, lepas tu you makan, tahu-tahu you dah selesai masalah. Tak kan? So they are all your volunteer action. So that's coping conscious. Coping mechanism does not necessarily means it's a good or bad thing. Coping mechanism is something in general. So kalau kita divide further, ada coping mechanism yang healthy, ada coping mechanism yang unhealthy. And contoh, ada orang bila dia ada masalah, dia mengamuk. So dia cope dia dengan problem dia, tapi mengamuk tu is unhealthy. Ada orang dia cope dengan problem dengan dia pergi minta tolong. So both are behavioral coping, tapi satu maladaptive, satu productive. And ataupun ada orang dia cope dengan dia tidur. And so tidur tu can be macam Zul tadi lah. And so tidur tu can be either positive bila dia bangun dia rasa fresh, dia deal with the problem back, ataupun dia boleh jadi maladaptive bila dia tidur, dia bangun, dia buat macam masalah sebelum tu tak berlaku. And so both can so it can be something yang neutral to start with, tapi dia end up healthy or unhealthy. So healthy or unhealthy ni dia depends dekat apa outcome dia. And so kalau crisis tu resolve or crisis tu boleh dihadapi dengan baik, so that means it's a healthy coping. And so contoh ada orang dia fail, so dia cope dengan dia tukar cara belajar dia ke, dia cope dengan dia pergi ubah lifestyle dia ke whatever. Lepas pada tu dia jadi improve contohnya. So that mean that whatever coping yang dia buat tu jadi healthy. Tapi ada orang bila dia fail, dia move on, so-called move on, dia kata aku tak nak fikirlah, aku tak nak buat apa, end up dia just continuing the same pattern of behavior, akhirnya come back to exam, fail lagi. And so maksudnya the way dia cope and dia rasa okay tu sebenarnya unhealthy untuk dia. So that's coping lah. So it started off as a defense mechanism, something yang we don't realize we do it, and tapi bila dia berterusan jadi pattern, so dia start developing into symptom lah. So bila symptom tu berlaku over time, ada associated symptom, dia jadi syndrome, and eventually bila dia start ganggu kita punya function, dia jadi disorder lah. So dissociation itself is actually merely a symptom lah. And dia bukan, kalau kita ada dissociation, tak semestinya kita ada penyakit dissociative disorder. And so in this case, symptom pun betul, defense mechanism pun betul lah. Alright, dissociation, you all boleh nampak screen kan?
Boleh.
Ingat hang lagi tadi. So second, dissociation can be part of criteria for the following disorder except PTSD. Boleh ke tak boleh? True, false?
Betul.
True. Okay, so PTSD you all belajar kan dia ada cluster of symptoms. So dia under apa?
Anxiety.
Bukan. PTSD itself dia ada cluster of symptoms. So dia ada avoidance, dia ada hyperarousal. So dissociation in PTSD ni under apa?
Avoidance.
Avoidance. Bukan. Dia under negative emotion, negative associated emotion. Okay. So sama lah, ada orang dia depressed, ada orang dia dissociate. B, acute stress disorder. True or false?
Visualization.
Acute stress disorder. True or false?
True.
Acute stress disorder ni is actually a mini version of PTSD kan? Okay, so people can present with dissociation in acute stress disorder. Sebab acute stress disorder, one of the precipitant is trauma. And so whenever you face trauma, then there is a possibility that you can experience dissociation. Panic disorder, true or false?
False.
False. Ada orang yang berbeza pandangan? Semua orang rasa false?
Maksudnya ada derealization kot.
Derealization tu salah satu jenis dissociation lah.
Oh, Betul lah, betul.
Okay. So panic disorder, nak diagnose panic disorder kena ada panic attack. Salah satu simptom panic attack adalah patient can presented dengan depersonalization, derealization, which is a form of dissociation. Remember, dissociation ni dia boleh jadi dissociate. Nanti kita cerita kat bawah tu. Dissociative disorders are characterized by a disruption of the following except consciousness, memory, identity, emotion, thoughts. A, B, C, D, E.
A.
Consciousness.
Ada yang ada different answer?
Ada. E. Thought.
Thought. Lain?
Emotion.
Emotion.
Emotion betul. Emotion.
Emotion. Last semua ada lah. Okay. So, bila orang tu dissociate, dia boleh dissociate in all aspects. Bila dissociate dissociative amnesia, dia dissociate memory. Bila dissociate identity, dia dissociate identity. Bila dia dissociate identity, identity tu encompasses emotions and thoughts. So maksudnya bila orang dissociate identity, dia boleh ada loss of emotions and loss of thought as well. Maksudnya dia rasa emotions yang dia ada tu bukan emotion dia. Sebab identity tu yang marah, bukan dia yang marah. And thought pun sama, bukan saya yang fikir macam tu, dia yang fikir macam tu. So dia dissociate daripada fikiran dan emosi yang dia ada. So they are all true except one, which is consciousness. So consciousness is not affected in dissociative disorder. Consciousness ni is you punya kesedaran lah. Kalau you punya consciousness affected, maknanya you ada delirium lah, ataupun you ada loss of consciousness sebab injury ke trauma, head trauma dan sebagainya. And that doesn't happen in dissociative disorder lah.
Doktor, dalam cerita ni consciousness tu dia tidak melibatkan sama ada dia sedar ataupun dia tak sedar dia dah jadi orang lain ke?
Bukan yang tu. Consciousness in this context maksudnya dia pengsan.
Okay, faham.
The following are true regarding dissociative identity disorder except it is previously called a multiple personality disorder. True or false?
True.
True. Okay. True. True or false? Betul. Characterized by two or more distinct identities or personality states.
True. True.
True.
True. Okay. More common in male. True or
False.
false?
False.
Okay. False. More common in female. In fact, generally speaking, they are more common. All dissociative disorder are common in female except dissociative amnesia where dia tak banyak sangat beza lah. Present with recurrent gaps in memory. True or false?
Oh,
False.
False.
True or false?
false.
False.
Also, nanti dekat dissociative amnesia tu.
Jawapan dia true True sebab apa? Sebab orang yang original, okay, orang yang original. Contohnya siapa tadi? Zul tadi orang yang original kan. So Zul dissociate jadi Aiman, jadi Zaki, jadi Faizal. So bila dia jadi orang-orang yang lain ni, yang Zul tadi tu, dia akan ada memory gaps. Sebab waktu dia jadi orang lain tu, dia tak ingat benda tu dia buat. Itu maksud present with recurrent gaps in memory. Contohnya, ada orang yang dissociate, bila dia dissociate tu dia jadi individu yang ganas. And so individu yang ganas tu buat onar lah, and dia pukul orang dan sebagainya. So bila dia back to Zul, yang original tak Zul lah, back to original person dia tadi tu, dia tak ada recollection. Kenapa tuduh aku pukul orang ni? Kenapa tiba-tiba tangan aku ada darah? Contohnya, itu maksud recurrent gaps in memory. So they may present dengan recurrent gaps of memory. True yang you kata dissociative amnesia present dengan gaps in memory, tapi DID pun boleh present dengan recurrent gaps in memory. Faham Number 5, before diagnosing DID, the following causes need to be excluded except A, substance. True or false?
True.
True. Okay. Seizure. True or false?
True.
True.
Sense of urgency. True or false?
Apa maksud dia, doktor?
Maksud dia, doktor.
sense of urgency. Kalau you all baca diagnostic criteria dissociative identity disorder, mesti you jumpa sense of urgency. Sense of agency bermaksud belongingness. Maknanya siapa punya ni. Itu maksud dia. And so orang yang ada DID, dia ada problem in sense of agency. Sense of agency maksudnya yang cakap tu tadi siapa? Kalau kita yang ada normal sense of agency maksudnya ini semua saya punya. Ini baju Dr. Nizam, ini Dr. Nizam punya percakapan, itu saya punya kata-kata, itu saya punya lecture, itu saya punya student. Semua tu dia punya. Dan maksud dia ada normal sense of agency. Semua ni belong to me. Mana I understand, I have full awareness that those are the things that represent me as an individual. Tapi orang yang ada DID, dia ada problem in sense of agency. So we don't exclude sense of agency in DID, but that is something that we want to understand, want to include lah. And so jawapan dekat sini, of course lah, we don't exclude that. Ordinary forgetfulness. Ordinary forgetfulness.
False.
Okay. Personality disorder.
True.
Do we exclude personality disorder? Do we exclude ordinary forgetfulness atau tak?
Oh.
Jawab soalan saya maksudnya. Bila before kita diagnose DID, do we have to exclude ordinary forgetfulness ke tak?
Nah.
Kena.
Yes lah. Betul lah.
Yes.
So betul lah. So personality disorder kena exclude ke tak kena exclude?
Kena.
Alright. So faham tu dulu lah. So number 6, type of memory affected in dissociative amnesia. True, false? Recall? True or false?
True.
True.
True or
Recent memory. Amnesia.
true? Okay. Registration?
True.
Registration ni apa? Registration ni apa? Registration ni working memory. Contohnya you order dengan cashier kan? Nak nasi goreng satu, so pun dia ingat nasi goreng satu. So that's registration, register memory. So orang ada dissociative amnesia, dia tak ada registration problem. Dia still, maknanya kalau orang tu tengah dissociative amnesia, you bagi dia 3 benda, you suruh dia ulang balik 3 benda, dia tak ada problem. Okay. So registration tak ada problem. Autobiographical ada problem ke tak ada problem? Affected or not affected?
Affected.
Autobiographical ni apa?
Personal information.
Personal information. Okay, so kalau you tanya dia lahir kat mana, sekolah mana dulu, and so it might be affected. Intellectual, affected or not affected? Affected?
No.
Intellectual tak affected. And so contohnya kalau dia tengah amnesia, you tanya 2 tambah 2 berapa? And so dia still boleh remember 2 tambah 2, 4. So intellectual tak affected. Semantic affected or not? Semantic ni apa?
Not.
Semantic ni naming. Macam contohnya saya tanya you all body parts. Saya tanya you all clock parts. Ni boleh tak namakan ni apa, ni apa, ni apa. And so semantic tak affected. So semantic ni affected kalau ada specific part of the brain, traumatic brain injury, they might affected. Alright.
Betul. I just want to ask about the yang intellectual tadi. So kalau dalam DSM tu dia ada sebut pasal they have trouble in school, in occupation, in school. So tu bukan intellectual lah.
The trouble in school
ke masalah dia tak masalah macam dia nak comprehend ke macam mana?
Kan dia macam ni, contoh trouble in school, trouble ini because you lost you punya awareness that that's what you have been doing. Macam contohnya kalau you ada medical, you ada contohlah houseman. houseman yang ada something traumatic happen kepada dia, dan masa dia ada dissociative amnesia tu dia tak boleh buat kerja dia as a doctor. So bukan maksud dia ada intellectual disability, dia jadi macam bengong-bengong macam tu. Tapi sebab dia lost dia punya skills, dia lost dia punya awareness that dia once was a doctor. Itu maksud dia. Okay, faham?
Okay, Doktor, faham.
Alright. Number 7, depersonalization, derealization can be part of normal experience. True, false?
True.
True, okay.
True.
The following medical condition can give rise to depersonalization, derealization. Accept. Tapi kita tengok true, false ya. Nah, satu-satu. Hypoglycemia. Yes, true or false? Can hypoglycemia cause depersonalization, derealization? True, false?
True kot. True.
True kot. And true. And sebab basically hypoglycemia can induce delirium. Delirium can present as depersonalization, derealization. Sebab dia alter or dia affect brain functioning. Hyperventilation. True, false?
Doktor, bukan dia kata accept ke doktor?
Tak, kita tengok true, false.
Oh, okay.
Saya tanya satu-satu. Hyperventilation, true, false? Boleh ke tak boleh? Can hyperventilation cause depersonalization, derealization?
Cannot.
Cannot. Can hyperventilation make somebody become delirious? Boleh lah. Hyperventilate, you dapat carbon dioxide intoxication kan? And you dapat increase in you punya carbon dioxide in the body. So dia akan affect you punya brainstem. So anything that can cause, essentially anything that can cause delirium can present as depersonalization, derealization. Migraine?
True.
Hypothyroidism? Tak. Migraine boleh. Migraine kan, orang yang migraine kan ada aura. Okay, so aura and migraine tu boleh jadi apa-apa. So biasa siapa yang ada migraine yang teruk ni biasa akan experience aura, dia nampak zigzag ke, flashing lights ke. Tapi ada orang yang dapat migraine, kalau dia pergi dekat klinik neurologi, dia rasa everything is small ataupun jadi besar. So that is actually derealization. It can happen. Hypothyroidism? Boleh ke tak boleh?
No.
Tak boleh.
Tak boleh. So ni endocrine related problem. Dia tak affect sangat brain directly. So CNS infection of course, and anything that affect brain akan affect, akan potentially cause delirium. Alright, last one. I feel like what's around me was unreal. I wanted to say that it was heaven, but I know it was not real. This describe apa? Fugue state, dissociative trance, depersonalization, derealization, delusion.
Derealization.
Derealization.
Okay, good. Kenapa? Why is it not delusion?
Because the patient know that this is not real.
So dia ada insight. So itu yang membezakan antara delirium dengan membezakan antara depersonalization, derealization dengan delusion. So depersonalization, derealization, reality testing intact, they still know what's real, what's not real. And delusion, reality testing impact. Dia dah tak tahu dah mana yang betul, mana yang tak betul. Depersonalization, derealization is perceptual disturbance, delusion is thought disturbance. And so dia kepercayaan. Tapi derealization is the feeling that you experience, the way your brain interpret your surrounding. Okay. Alright. So
Kata fugue macam mana?
Fugue. So fugue kan ada dalam lecture ada kan? So fugue tu is when you adopt a different identity as a result of amnesia. So dissociative amnesia, you ada loss of memory. Siapa aku ni? Tapi bukan semua dissociative amnesia akan resulting in fugue. Certain amnesia, and bukan setakat dia stop dekat amnesia, dah lah dia tak ingat dia ni siapa, tapi dia regain ataupun dia dia build new identity untuk fill the gap yang dia tak ingat dia tu siapa. And so that's dissociative fugue. Yang ni pun extremely rare lah. And so saya pun tak pernah jumpa orang ada dissociative fugue, tapi it has been reported in literature lah. Dissociative trance tu merujuk kepada kalau dalam kita punya local konteks, kalau dissociative trance ni dalam local konteks ni macam kena rasuk lah. And so yang kena rasuk, hysterical, yang kita panggil dissociative trance. Dissociative trance maksudnya dia berlaku sekejap je. Dia berlaku pada that period saja. And lepas tu the rest orang tu jadi normal balik. So kalau orang kena rasuk tu for whatever reason lah, and so kita dalam medically kita label it as dissociative trance. Okay, alright. So that's all. Just a few questions around topics of dissociative disorder. Untuk year 4 ni adalah 1-2 soalan on dissociative, one best answer, yang senang-senang je lah. Yang insyaAllah saya tak bagi susah-susah. It's a difficult concept to understand. You dapat basic ideas tu pun cukup dah lah. Okay, alright, that's it. That's all for today. Nanti my group will try to find one session untuk last discussion. The rest ni I'll see you in 5 years pula. I'll see you in year 5 lah, insyaAllah, kalau diorang still require me to fill in some lecture.